Thank you very much, Case. We go back many years, and Case worked with me in Dublin, and Cassim, who was another great friend and colleague who was also in Dublin. Now, I'm a bit of a dinosaur because I did a lot of, and I still do a lot of refractive in pediatrics, which is probably to be frowned upon by most of the purists. And so I thought I'd talk about my experience in refractive surgery in the pediatric age group. I have no financial interest in any of the subject matter. And of course, the first thing to say to you is that there's a huge mindset difference between refractive surgeons and pediatric surgeons. Refractive surgeons by nature are very aggressive. Pediatric surgeons are very conservative in my experience. And so to say to you is that many years ago when I started out, I used to go to the APOS meetings in America, and we were doing unilateral congenital cataracts, and I found when I came to Dublin, contact lens care was appalling, so we had to do implants or else do nothing. And in America, I was an adult surgeon as well, doing lots of adult cataracts. And of course, a pediatric ophthalmologist only do pediatric cases, and I thought it was very strange that people were standing up and presenting expertise, having done about 5 pediatric cataracts a year when I was doing hundreds of adult cataracts. And if you look at what has happened, all of the advances in pediatric cataract surgery have happened through adult phaco technology. So first of all, to say to you, it's not widely performed refractive surgery in children, and what are the indications, and there's the economics of it. And then there's local versus general anesthesia, because most young kids will need a general anesthetic. And then there's a decision as to whether you do LASIK or whether you do PRK. And then the third thing is, what is the age of surgery when you can do these? Because you've got to do them very early on if you're going to avoid amblyopia. And then there's specific problems in children. There's the anesthesia, there's the preoperative workup. You can't do all the things you do in adults, the scanning, etc. And then there's the aperture, where you have to do, in many cases, if you're going to do a LASIK in young kids, you've got to do a lateral cantotomy. There's the type of refractive surgery, and again, of course, there's the postoperative care. And the difference in the pediatric eye, there's increased growth to mid-teens, the sclera and cornea less rigid, and you have a developing visual system. Just to give you briefly the types of refractive surgery, obviously, there's the extraocular procedures, there's the LASIK, PRK, LASIK, and epi-LASIK, all of the same, much of a team of the same thing. They're all surface laser. And there's the intraocular lenses, and there's the clear lens extraction. So these are the menu of refractive procedures that we have available. Excimer lasers have changed over the years. I started doing laser, as Kay said, many, many years ago, and we're now on our 5th laser, excimer laser, and these have become very sophisticated with trackers, etc. LASIK has changed as well. We up to recently used alcohol. Now we do what's known as a transepithelial PRK, and we can do it all with laser, and it's made, obviously, the visual outcomes much better, much quicker, reduce the pain, although pain is still an issue. And then, and as you know, it's a procedure using 193 nanomu of argon fluoride laser, and we remove Bowman's layer. And it's interesting that if you look at the literature many, many years ago, when something Bowman, an English ophthalmologist, described Bowman's layer, the view was that if you took Bowman's layer away, you destroyed the cornea. Of course, we know that's not true anymore. LASIK, then, on the other hand, has come a long way. It came after LASIK, or PRK. It's a magic procedure. It's probably, up to recently anyway, the most commonest operation done in the world. And it's gone from all the keratomes, which initially had all the problems, to a very sophisticated femtosecond laser, which is an amazing instrument that can cut 110 micron flap, or 100, you can set it at any level. And so this is how refractive surgery has proceeded. In terms of children, the first studies were published in 2008, and this is a study by Bill Assel from Calgary, and there were others as well using PRK, and I use PRK as well in children, or LASIK as it called it. And the initial results, people claimed, were very good. People were doing high degrees of myopia, high degrees of hyperopia, which really were not being the same thing that we were doing in adults, because high degrees of hyperopia, you get lots of haze, regression, and of course the other thing was the pain, although pain in children after LASIK is not half as bad as the pain you got in adults. our first publication, we did a lot of LASIK. We did LASIK as well, published in the British Journal of Ophthalmology in 2004, a small series of patients, which we were quite successful with and avoided the complication because I had a system in Dublin where I could give general anesthesia and excellent backup arrangements, and because we were doing a lot of adult refractive surgery, so we were very familiar with the technique. And this was a 10-year follow-up, which we showed very good results in a small number of patients, although they do regress again, but nothing like from the initial outcome. These were very good outcomes. If we look at LASIK versus LASIK, LASIK is painless, quick vision, obviously all the advantages, and these are all advantages that I think are very much important in children. You need quick outcomes, because you want to start patching them and you want to move it pretty rapidly, whereas LASIK, on the other hand, there's a lot of healing going on afterwards, a lot of follow-up, and therefore it's much more slower outcomes. This is another paper. Take a refractive accommodative esotropia. I'm sure most of you have parents coming to you and their kids are still in glasses, and the alternative is contact lenses, and they want surgery, which shouldn't be done. And so therefore these kids are confined to glasses. And this was another indication that we found for LASIK. And I published one of the first papers on this in the British Journal of Ophthalmology in 2010, where we did refractive surgery in children with accommodative and non-accommodative strabismus, 1 year prospective follow-up. As long as you were selective in these kids, probably nothing but +5, we're giving you good outcomes. And we've done many of those since, and we've had follow-up papers and all of this. And other people have done the same thing again, as we have done, and with equally good outcomes. The other important area in refractive surgery in children is intraocular refractive procedure. And these are the two lenses that have stood the test of time over the years. There's the Artisan, which has been useful in aphakia, hyperopia, myopia, astigmatism, and then subsequently came along the Artiflex lens, which is mainly in myopia. And these became, I tended to switch to many of these in children when I got from it. Obviously I'd used a lot of them in adults. And this is one man that you've got to give some credit to. It's Jan Worst, a Dutch ophthalmologist who was the first person to invent these. And this is the Artiflex. It's a very neat foldable implant, and you can slip it into the eye through a small incision. And again, it's useful in high myopia. And this is when it's inclavated to the iris, and you have to do a peripheral iridectomy. And these are useful as well in aphakia. You can put them in front of the pupil, behind the pupil, particularly in children who you've left aphakic and you have no capsular support, and where it's almost impossible to open the capsular bag. And these have become a very useful tool in this area. And this is an example of one such child that the unilateral cataract 10 years ago, ended up with about a -10 or 11, good visual outcome, but ended up having to put an Artiflex IOL in to counteract the high myopia very successfully. These are an example of another group of patients that we did. I think was published in the Acta Ophthalmologica, foldable iris fixated intraocular implantation in children. And these are children with a high hemetropia with neurobehavioral disorders. And we published 2 papers on this. One is JAPOS. And these are a whole lot of children where they are Down syndrome, kids with neurobehavioral disorders, a few with ROP, although ROP is limited enough in terms because of the arrested anterior segment development, and you need a deep anterior chamber. And these kids, as you can see, I don't have time to go through it, but you can see there were high degrees of myopia. They will not wear glasses. Contact lenses are impossible. And these are children that we did a whole series of these and published it, and with excellent outcomes. And we did quality follow-up studies on these kids. And these kids have done remarkably well. And of course, this is refractive surgery in children with special needs. And of course, it helps them to they're in a state of blur all the time. And part of this then is why their behavior probably is such. And it has reduced it stimulates them and gives them a new life. And it's a really important indication for refractive surgery in this group of children. What are the advantages of implants? Well, high myopia, hyperopia, they're reversible, you can take them out. You can do bioptics, you can do the lens in the eye, and you can do the corneal laser. They give you quicker rehabilitation, which in my view is a very important advantage in children. There are no special conditions required. You can do it as a non-refractive surgeon. You're less expensive. You don't have to buy an excimer and a femtosecond, which will cost you about $600,000. And okay, there are disadvantages. The biggest thing people say to you about these implants is, oh, endothelial cell loss. I put a lot of them into adults. I've moved now in adult refractive surgery from Artiflex, Artisan, to the Collamer VQ8, which has the hole in the middle, which is the advantage. You don't have to do a peripheral iridectomy, and these give excellent outcomes. But there's a sizing issue, and this is the problem in children. The white-to-white has been important. I saw a series recently published by a doctor in the United States with excellent outcomes. I must share I have grave reservations about them in children. Obviously, there's the risk of cataract, pigment dispersion. You can't put them into a shallow anterior chamber, so therefore the advantage there's not such an advantage in children who end up with high myopia after ROP. And then there's a question of dislocation. This is an example of a child, one of the children that I implanted who was suitable for an implant in ROP with a very successful outcome. And this is a child with implants in both eyes. I've shown you this slide already. So what are the other, this is a paper published in American Journal of Ophthalmology, and they concluded that refractive surgery is appropriate in children with severe anisometropia or bilateral ametropia that is resistant to conventional therapy. And of course, there's always in a lot of these papers the usual follow-on. This has to be a large, prospective, multi-center, rationalized clinical control time, which is virtually impossible in this area because the time you'd get a multi-center trial going and the numbers, and particularly in pediatric ophthalmology in America, where doctors only do pediatrics and where there's a big divergence in terms of refractive surgery, and refractive surgery is not done in hospital settings. This is a paper, Paolo Nuccio in Milan, who has done a lot of work refractive surgery for treatment of purely refractive accommodative. I've published a series of papers on children where I've done it for LASIK in accommodative esotropia. And of course, this is easier because these kids are bigger. They're 15 or more, and they're easier to do in terms of you don't need anesthesia and all that. I've been very reluctant to do surface laser on these children with hyperopia because of regression and so on. So what are the indications for refractive surgery in children? Well, obviously bilateral high myopia, myopic anisometropia, accommodative strabismus, and previous cataract surgery. When we put all these implants into these congenital cataracts, we knew that all of these would have this, in many cases, this incredible myopic shift, and there was a view that you'd have to take the implants out. I've never had to do that because I've been able to do a refractive surgery or put implants in. I recently reviewed the IATS study at, I think it was 5 years, and they've been taking some of these implants out of these kids they put in, and they have been re-implanting them without any problem, although I'm not sure. I'd be very reluctant at 5 or 6, 10 years to take an implant out of a child's eye. I think it would be extremely difficult. So then the next question, and the final one, is pediatric refractive surgery, laser vision, or phakic intraocular lenses. Well, what are the indications? They're phakic patients with inadequate capsular support. Children, I've done a whole series of children for lensectomy with ectopia lentis, very successful outcomes doing early surgery for the removing of the lens. Children with trauma, phakic patients, high anisometropia, intolerant to contact lenses, post-congenital cataract extraction with phakic IOLs, post-treatment of retinopathy prematurity, in a limited number of cases where the chamber is deep enough, bilateral high ametropia, those, as I've shown to you, where we've published a whole series of those with morbid neurobehavioral disorders or learning disability, children with high astigmatism, and of course children with accommodative esotropia. So these are really good indications and very successful procedures. So what is my conclusion? Well, laser surgery is safe. As a selection issue, you've got to select, not everybody is suitable. You've got to decide the right indications, whether you want to do a corneal laser or whether you don't put an implant in the eye. And I think, look, this is never going to be a huge money spinner. It's not going to be an awful lot of patients that you're going to have to deal with, but it is a useful thing to have in your repertoire to deal with these kids. And I think this is where the future lies. Thank you.
Thank you very much for this comprehensive lecture. I miss your lectures. Is there any questions?
Can I just ask, Professor O'Keefe, you mentioned high anisometropia being an indication in children, and my experience is that children are very tolerant of very high levels of anisometropia. Obviously, you do have the issue with the glasses being very asymmetrical, but what would your sort of guidelines on what levels you should be considering?
Oh, I mean, people -8, -10. I think these kids are very kids ideal for implants. And then you have the situation where anisometropia, where I agree with you, where kids tolerate this much better than any adults. But it is a useful thing to have, and you will get them out of their glasses. And some of these kids may not be tolerant to contact lenses, and contact lenses are not the ideal solution to these kids. So it is another useful thing to have, to say to parents, we can do this.
Sorry, Prof, we just have one more question.
Yes, a question here, maybe?
Oh, yeah. Oh, yeah.
Yeah, about the accommodative esotropia, I'm wondering, these patients present since age of 1 year, 1, 2, 3, 4. When do you start to talk with the parents about refractive
accommodative esotropia, you don't talk about them until they're well into their early teens.
18s.
Yeah,
Okay.
yeah, I mean, you don't touch them until then. These are the kids, and you and I must see them. The parents come in with their glasses and they want to know, doctor, they want muscle surgery, which is not what we do for them, because it's a focusing problem. And therefore, you can I mean, it's a limited number, because this works well up to about +450, +5 in hyperopia and laser. Beyond that, it doesn't work that well. So again, you can do a bilateral LASIK on these older kids, 15, 16, and you can, with great certainty, say to the parents they're going to be glasses free. But there are risks attached to all of these things. Let's not underestimate these. LASIK has risks attached to it. There's risks at the surgery in terms of doing the surgery, but it's got a lot safer with the use of lasers all the way, with the use of femtosecond laser. It has now made this very reproducible in terms of the flap size, etc.
Thank you.
I just have a question about, I know that's artisan is a good option, but now we're moving to ICL because I think it's safer even for kids. For the angle, because the angle is changed, what age do you think is the angle would be stable? What age of the patient for children, when is the angle size doesn't change after that, and you could safely do ICL?
Well, ICL, I haven't done any ICLs in children because of the reasons I mentioned, that I think the sizing is a big issue in ICLs, and if it's too, but I would put these into kids age 2 beyond, put iris fixated IOLs. I have done so in many in these kids.
Yeah, but what age do you think that the angle doesn't change in the growth eye? What age? As oversizing and sizing always issue with any age, regardless. But when you think it's the size of the angle, it doesn't change. The sulcus size doesn't change. What age you think is stable?
You mean the angle of the eye?
Yes, the sulcus to sulcus size.
I'm not sure really, but I think it's probably changes up to, it's not stable in a young child. I'm not sure what age it stabilizes at, I don't know.
Mm-hmm. Thank you very much.
I have a question. Good morning. I'm Dr. Thaleka. I'm a pediatric ophthalmologist. I have a 7-year-old child who has an isomyopia of about -11.5, and the other eye is a -0.5 myopia. He's never done any occlusion therapy. He is having amblyopia. Vision is just finger counting in the amblyopic eye. It's 6/6 in the good eye. And patient wants a refractive surgery, and I have been telling them it's not going to help because...
Well, it's not going to help. He's amblyopic in the eye. They're not going to get any vision in the eye. So, I mean, I think it's a pretty wasted exercise in putting him through a refractive surgery procedure with no gain.
And so how early do you think it
you'd have to do these at the age of 2 and onwards. I mean, you've got to do much earlier.
Yeah.
But at the age of 7, but counting
it's
fingers.
It's a lost cause, I think.
Sorry?
I think it's a lost cause unless he still tries to do full-time patching or something and try to...
Well, it's not really.
It's
you've
quite late.
got to bring up a child as well as an eye here. There's no point in patching. You're going to get nothing out of it.
Yeah, true.
So, and put him through a procedure with some risks and no benefit, not a runner.
It's too late, yeah.
Yeah.
Thank you so much.
Great. Any more questions from the panel? Previous talks? No? Okay, so we conclude.
With regard to tonic, I don't know who delivered that lecture, with the tonic pupils in children. Yeah, Louis, do you always, when do you scan them?
Well, for tonic people, I start to think about unilateral, bilateral. If it's unilateral disease, it's most of the time idiopathic, and I don't do anything unless it is associated with extraocular motility deficit, and this is when I start about other diseases going on. If it's bilateral, yes, I will most likely do further workup, but it's not urgent workup for them, unless, again, there is another indication like extraocular motility deficit or something else going on. But unilateral tonic pupil, idiopathic, I don't usually work it up. Thank you.